and slido.com. You can use your mobile phone or your computer to open the web page with slido.com. And you can enter AZ0925 to get into the page, or you can scan the barcode to enter the system. You can raise your questions at any time. At the end of the section, we will move to discussion part, and you can see the questions raised by different audience at the page. When you see the similar questions you want to raise, you can press the like button. The question will move up. So the more questions audience press like will move to the top of the screen. And speaker and moderator will choose the questions to answer it. Thank you for your patience. Let's welcome our moderator, Professor Wang.
Okay. Hello, Professor and the honorable audience. I'm Stephen Wang from Taiwan. I work in the National Taiwan University Hospital. I'm an endocrinologist. It is my honor to introduce Professor Insuki today for this lecture. And we know that 2 weeks ago or 3 weeks ago, there is two important studies about the EMPEROR study and the DAPA-CKD were published in NJM 2 weeks ago and this afternoon. So today we are very honorable to introduce Professor Insuki for the role of SGLT2 inhibitor in heart failure and prevention in the renal effect type 2 diabetes. Professor Insuki, can you hear me?
Yes, I can. Can you see my screen?
Yeah, I can see it very clear.
You can see my screen. Okay, so I will.
And I will introduce briefly for the Dr. Silvio Insuki. Professor is a professor in the Yale School of Medicine in New Haven, Connecticut, United States, and where he serves as a clinical chief of section endocrinology. He is a medical director for the Yale Diabetic Center in Yale New Haven Hospital. Professor Insuki received his undergraduate degree in the Fordham University in New York and medical degree from the Harvard Medical School in Boston. He completed residency in the internal medicine and the fellowship in endocrinology metabolism in Yale New Haven Hospital. And Professor Insuki has authored and caused about over 500 manuscripts and monograph, textbook chapter and abstract, some leading biomedical journals, including the New England Journal of Medicine and the JAMA. And he is lectured nationally and internationally level for a wide variety of topics, mostly involve the clinical management of diabetes. As I know, Professor also interested for the pituitary disease and adrenal disease and see the patient for such service. His current research interests including pharmacology, anti-hyperglycemic therapy in both inpatient and outpatient setting, and the linkage for type 2 diabetes, insulin resistance, and cardiovascular complication. And he has leadership for the role of several large clinical trials related to diabetes medication and their cardiovascular impact. Professor Insuki has a large clinical practice involving a broad spectrum of endocrine disease, including diabetes, adrenal disease, pituitary disease, and the thyroid. And today, we are vulnerable to introduce Professor Insuki for this topic, role of SGLT2 inhibitor in heart failure prevention and the renal effect in type 2 diabetes. Let's welcome Professor Insuki.
Thank you very much. It's a pleasure to be with you this evening. I guess over there it's morning here. And I've been asked to update the group on the role of SGLT2 inhibitors, both in heart failure as well as their renal impact in patients with type 2 diabetes. So these are my disclosures. Now, one thing that we've learned, and some of this emanates from our experience with the SGLT2 inhibitors, is this interdigitation between metabolism, cardiovascular disease, and renal disease. And I think keep this figure in mind as we describe the important impact of SGLT2 inhibitors, not only on cardiac function, but also on renal function. Now, we all know, I know there's nephrologists and cardiologists listening this evening, and we all know that diabetes increases the risk of heart failure. On the left side is data from the SOLVE-P study that demonstrate that individuals with diabetes have a more than 50% increased risk of developing heart failure over time than non-diabetic peers. On the right are NHANES data from the United States, And as the nephrologists know, the presence of diabetes increases the risk of CKD, whether we define that by the development of albuminuria or a decline in GFR. In fact, it's interesting to note, and these are now Scandinavian data, showing that the first complication as a clinical manifestation in patients with type 2 diabetes is actually either heart failure, 24%, or chronic kidney disease at 36%. So 60% of the first complications in patients with type 2 diabetes have to do with left ventricular dysfunction or decreases in GFR or albuminuria. Now, this portends a poor prognosis as well. So in individuals who develop heart failure, the cardiologists know that the mortality is quite high. These are data from the UK. On the right side is the similar relationship between a declining GFR and the development of end-stage renal disease, as well as mortality. So bottom line, the development of either left ventricular dysfunction or a decline in GFR increases mortality risk substantially. In diabetes patients specifically, when incident heart failure occurs, one can see, and this is also United States data from a Medicare population. This is obviously an older population, older than 65. More than 100,000 individuals were tracked. And you can see that incident heart failure increases mortality substantially compared to diabetic patients who never develop heart failure. And you can see the mortality over 5 years approaches 80%. Moreover, once heart failure develops, it actually increases the risk of renal dysfunction. Now, this may relate to decreasing in cardiac output, the use of high potency diuretics, a variety of reasons, but heart failure is associated with a more rapid decline in glomerular filtration rate, as well as incident CKD. These are data from the Veterans System in the United States. And conversely, a decline in GFR or even worsening albuminuria seems to increase the risk of developing heart failure. These are data from the CKD prospective study, which is a prospective analysis of hundreds of thousands of individuals with CKD. Increase the risk of renal dysfunction. Now, this may relate to decreasing in cardiac output, the use of high potency diuretics, a variety of reasons, but heart failure is associated with a more rapid decline in glomerular filtration rate, as well as incident CKD. These are data from the Veterans System in the United States. And conversely, a decline in GFR or even worsening albuminuria seems to increase the risk of developing heart failure. These are data from the CKD prospective study, which is a prospective analysis of hundreds of thousands of individuals with CKD. Now, one would think that when we're discussing complications of diabetes, that tight glucose control, in other words, reversing the major metabolic abnormality of diabetes, which is, after all, hyperglycemia, should abrogate the complications that are linked to hyperglycemia. Unfortunately, that's not the case, at least for heart failure. We do know that decreasing hemoglobin A1C is linked to decreases in retinopathy, neuropathy, and nephropathy, mainly albuminuria, although that's a harbinger of progression of CKD. But on a cardiovascular basis, the control of glucose has very little impact on the prognosis, whether it's MACE, major adverse cardiovascular events, or heart failure. And since we're discussing heart failure today, I thought I'd show you this interesting meta-analysis, pooled data from the 4 largest studies in diabetes that sought to determine, type 2 diabetes, sought to determine whether improving glucose control had an impact on heart failure hospitalizations or heart failure mortality. You can see now UKPDS, ACCORD, ADVANCE, and VADT, the number of heart failure hospitalizations or mortal events here, and the point estimate using pooled data being perfectly neutral. In other words, the hazard ratio 1.00, you can't get more neutral than that. Summary is that the control of glucose has very little impact on avoiding heart failure hospitalizations. Well, what about individual glucose lowering drugs? So on the previous slide, we were discussing the overall concept of tight versus conventional glucose management. What about looking at individual glucose lowering drugs and whether they may have a specific benefit on the cardiovascular system or potential detrimental effects as well? Well, on this slide, I've identified the 7 major drug classes used in the United States. I do understand that in parts of the world, particularly in Asia, alpha-glucosidase inhibitors are used more commonly, but they have very little penetration in the United States. We use insulin, sulfonylureas, metformin being the most commonly prescribed agent, SUs probably still being the second most common, TZDs or thiazolidinediones, or what are sometimes nicknamed the glitazones, DPP4 inhibitors, sometimes nicknamed the gliptins, GLP-1 receptor agonists, which are mainly injectables, as are the insulin formulations, and the new kid on the block, new since 2013, 2014, so maybe 6 or 7 years old, the SGLT2 inhibitors, and I know those are increasing in popularity throughout the world, including in Asia. These are the generic names of the formulations that are on the market, at least in the US. I do understand that there are additional SGLT2 inhibitors available in some Asian countries. And this is the hemoglobin A1C reductions that one might expect with these compounds. Their mechanisms of action, which are for the most part distinct, specifically for the SGLT2 inhibitors, which is the topic today. The mode of action is to increase urinary glucose excretion. Remember that in the normal situation, the kidney holds on to glucose unless the glucose threshold is superseded at a plasma glucose concentration of 180 milligrams per deciliter, which is 10 millimoles. So if the glucose is maintained under that, no glucose gets into the urine because of SGLT2, to some degree SGLT1, but SGLT2 is the major transporter reclaiming glucose back into the plasma from the glomerular filtrate. In diabetes patients, that is actually abnormally high, the threshold. So individuals with type 2 diabetes have been demonstrated to have a urinary glucose threshold of 230 milligrams per deciliter versus 180. Therefore, the kidney seems to want to hold on to glucose more in patients with diabetes, and the SGLT2 inhibitors, as its name would suggest, block the reabsorption of glucose from the proximal nephron, increasing glucose excretion, lowering plasma glucose levels, and as we'll see later on, they do have other benefits as well. And obviously, with any medication, this is not pertaining simply to diabetes, but you can make a list of antihypertensive agents, lipid-lowering agents. There are positives and negatives, in other words, benefits and risks. And we'll talk about some of these later on, but the point I wanted to make is that every medication has some advantages as well as disadvantages. And then on the right side, the right column, is the important notation that each of these medications come with some cost, a fiscal cost. And obviously it's very different from country to country, depending on the health system. But on average, the sulfonylureas, metformin, and pioglitazone, which is the main TZD that is available today are extremely cost effective in terms of hemoglobin A1C, although they at least with the SUs, they're not known to have any specific cardiovascular benefits, although all medications probably have a microvascular benefit, because we do believe in the glucose hypothesis that any drug that lowers glucose should have an ultimate effect on retinopathy, albuminuria, neuropathy as well. Now, what are the effects of these medications in heart failure? That's the topic today. Insulin and sulfonylureas are probably neutral. That's the bottom line from many trials that have been conducted, sub-analyses. It's true that insulin in some observational studies is associated with an increased heart failure cases, but that's probably because sicker patients end up on insulin, but not a true effect from insulin itself. I point to the Origin study demonstrating a neutral effect, and I'd point to the Carolina study showing a neutral effect from sulfonylureas. With metformin, I think the verdict is still out. Conceptually, metformin could decrease heart failure episodes. We published a study a number of years ago showing that being discharged from the hospital after heart failure with metformin decreases rehospitalization rates and mortality, but there's been no big clinical trial of metformin in this regard. What about the TZDs? Well, these were very controversial. They still are to some degree. The glitazones probably improve cardiac function, so you think that they might decrease heart failure episodes, but they have this effect on the distal nephron of increasing sodium retention, and that has been clearly associated with an increase in heart failure hospitalizations. Now, I draw this line because it's between the TZDs in the mid-1990s and the DPP-4 inhibitors in the early 2000s that we have a clear distinction in terms of the level of evidence. Why? Well, in 2008, in the US, the FDA, but in your country's other regulatory bodies, began to mandate that these newer glucose-lowering agents would be submitted to extensive evaluations to demonstrate cardiovascular safety. I don't want to get into the rationale behind this, but suffice to say that drugs prior to 2008 had raised controversy as to whether glucose lowering was sufficient to improve cardiovascular events, because cardiovascular events was the major reason for mortality in patients with type 2 diabetes. And some medications that had either come onto the market, I think about rosiglitazone, one of the TZDs, and other drugs that were almost coming to market, had shown concerning signals of cardiovascular harm. So the FDA and EMA and other bodies said, okay, let's put a proviso on new medications coming onto the market that we need to demonstrate at the very least cardiovascular safety, not even efficacy. I mean, there was loss of hope that these drugs could reduce cardiovascular events, but the regulatory bodies were simply concerned with safety. Long story, sorry, but it means that the drugs that come after the guidance, so DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, kind of the alphabet soup of diabetes management, were each submitted to extensive, large cardiovascular outcome trials to demonstrate safety. So the era of diabetes before and after these regulatory guidances is distinguished in the transition to the DPP-4 inhibitors. This is what happened. This is the outpouring of cardiovascular outcome trials. More than 200,000 patients at one time were involved in these trials throughout the world. And I know that some of the countries represented this evening by our listeners were nicely represented in many of these trials, including China and other countries in Southeast Asia. At the top, we have the DPP-4 inhibitors. In the middle, the GLP-1 receptor agonists, and at the bottom, the SGLT2 inhibitors. I won't bore you with the data from the DPP-4 inhibitors. It's not exciting. It showed neutrality for the most part in each of these trials. All the gliptins were neutral for major adverse cardiovascular events. In other words, these drugs neither harm nor hurt. Did not help nor did they harm patients with cardiovascular disease, high risk for cardiovascular disease, and type 2 diabetes. Now, there was an odd exception in that HHF, which the cardiologists know as heart failure hospitalization or hospitalization for heart failure, was puzzlingly increased in the SAVOR study using the DPP-4 inhibitor saxagliptin. You can see the hazard ratio was 27% increased, and that was statistically significant, whereas with alogliptin, the HHF endpoint, these are secondary endpoints, not primary endpoints, MACE was primary, the hazard ratio was numerically increased, but not statistically significant. Nonetheless, in many countries, there was a warning in the saxagliptin and even the alogliptin label to not use the medication in patients with heart failure, or at least to be aware of the potential for increasing heart failure hospitalizations, whereas with sitagliptin and linagliptin, that effect was not seen. So, neutral, maybe a question mark, maybe there is some discrepancies from one drug to another. Now, the next drug class that I wanted to review are the SGLT2 inhibitors. This evening, we will not be discussing the GLP-1 receptor agonists, but as you'll see in the guidelines, those clearly are also being noted by the writing committees of these guidelines as being important medications for reducing cardiovascular events. But based on our topic today, I wanted to focus on the SGLT2 inhibitors. Now, the first study that suggested a benefit for a glucose-lowering agent as regards to cardiovascular disease was the EMPA-REG outcome trial and the SGLT2 inhibitor empagliflozin. This was a landmark trial because it was the first time that we proved that we could indeed reduce cardiovascular events with a glucose-lowering drug. The most prominent conclusion or outcome from EMPA-REG outcome was the cardiovascular death component of the composite of MACE. You remember that MACE is non-fatal MI, non-fatal stroke, and CV death. Non-fatal MI and stroke were not significantly reduced, but CV death had a huge improvement, 38%, that drove the MACE outcome of 14% relative risk reduction. The other interesting observation from EMPA-REG outcome was this very early divergence of the event curves. Now, you know that in atherosclerosis types of trials, you tend to see this, sorry, I think I touched the wrong part of my screen. You tend to see this divergence of the event curves somewhere around 12 months. That's logical because you're trying to prevent atherosclerosis, it takes some time. You don't see this divergence starting at about 2 months, which is what we saw in the EMPA-REG outcome trial, suggesting that the drug may not be working through conventional anti-atherosclerotic mechanisms. Still don't know what the mechanisms are. Some say there's a hemodynamic effect and left ventricular offloading because of the diuretic properties, but other diuretics don't do that. So it's still not quite clear. There's a metabolic hypothesis that an increase in ketone bodies induced by SGLT2 inhibitors may be a more efficient fuel source for the heart. There's lots of studies, lots of investigations and work to be done in terms of understanding this effect, but it is a real effect because it's been replicated by the other cardiovascular outcome trials using additional SGLT2 inhibitors. So here are the results of the EMPA-REG outcome trial reductions in MACE driven by CV death, and then this very important and surprising heart failure hospitalization benefit and a CKD progression benefit. And again, we're linking those two events in many patients who have heart failure leading to CKD, CKD leading to heart failure, as we've already discussed. Canagliflozin was studied in CANVAS, identical 3-point MACE, no reduction statistically significant in CV death, but still this very consistent improvement in heart failure hospitalizations and CKD progression. Dapagliflozin and DECLARE. Now, I would point out that DECLARE is more primary prevention patients. These are individuals with risk factors, not necessarily with established CVD, which is what you saw in EMPA-REG and what you saw more of in CANVAS. So take that in mind when you look at some of the data. Here we saw point estimates under 1, but no significant effect on MACE or CV death. But again, this powerful effect on heart failure hospitalization as well as CKD progression. And then finally, CREDENCE, which was a renal study, but they did collect assiduously cardiovascular outcomes, and they demonstrated that, again, 3-point MACE, CV death, heart failure hospitalization, CKD progression, very, very similar to those findings from the original EMPA-REG outcome trial. Now, the heart failure hospitalization finding is so consistent, 35, 33, 27, 39% relative risk reduction, that it led to additional investigations as to what was going on. Well, the first paper here that I want to show you is from Zelniker and colleagues from the Brigham and Women's Hospital in Boston, here in Massachusetts in the United States. And what Zelniker did was to distinguish patients with eCVD, which is established CVD, across the 3 main trials. That this is not including CREDENCE. This is the first 3 main SGLT2 CV outcome trials. And for heart failure, in those patients with established CVD, the point estimate was 0.71, so a 29% risk reduction. And in the 2 trials that did not include only CVD patients, so we're talking about CANVAS and DECLARE, here you had multiple risk factor patients, no established CVD. I think it was about 34% in CANVAS and maybe 59% in DECLARE. Even here, even though they did not have known CVD, there was a huge reduction, a 36% reduction in heart failure hospitalization. Now, in most of these trials, heart failure was not a prominent baseline risk factor. A little bit more perhaps in CREDENCE, but in the 3 original trials, EMPA-REG, CANVAS, and DECLARE, 90% of patients did not have heart failure at baseline. So let's look at another way. Now, this is dividing people by the history of heart failure at baseline. And here you see point estimate 0.68, so a 32% risk reduction. And even those without heart failure, 0.71, 29% risk reduction. What this means is that these drugs, for some reason, still don't know the mechanism, improve the clinical outcomes in patients with heart failure, but also have a heart failure prevention effect. First time that's ever been demonstrated in diabetes, that we could use a medication, irrespective of glucose lowering, we could actually use a medication that reduces the risk of heart failure. Now, why might this be? As mentioned, we don't know. I will provide you a little bit of insights from what we called a mediation analysis from the EMPA-REG outcome trial. And here we control for the various covariates that we measured. And when the point estimate moves to the right, so it gets closer to the line of unity, that would suggest that there is an attenuation of the effect of the study drug when controlling for that covariate, suggesting that covariate may be important. Does not imply cause and effect, right? Because we did not measure every risk factor other covariates could be involved as well, but it may give you some insights as to what are the important mediators of this benefit. So you can see that when we looked at each of these risk factors, in this study, they're covariates, the needle is not moved that much, with the exception of the control of hematocrit and hemoglobin, which are responsible for 50 to 53% of the benefit of empagliflozin in the EMPEROR outcome trial, in this specific outcome, which is heart failure hospitalization. So hematocrit 50.7%, hemoglobin 53%. So about half of the benefit appears to be mediated through hemoglobin. Now, what about other trials? This is from the CANVAS study, and it's a very similar analysis looking at the heart failure hospitalization outcome and looking at covariates that would move the hazard ratio. And here I'll just blow it up for you. You can see that there is perhaps not as large an effect from hemoglobin and hematocrit, maybe about a 40%, but I think the bottom line is that these are important mediators of the benefits of these medications as regards to heart failure hospitalization. Now, one point I would like to make is you might be asking, well, what does hemoglobin and hematocrit have to do with anything? They actually are increased by about 3 percentage points with SGLT2 inhibitor therapy. We think this is related to plasma volume reduction, in other words, hemoconcentration, although other data would suggest that these drugs may actually increase the circulating levels of erythropoietin. So EPO drives red blood cell production, and it's conceivable that increasing oxygen delivery to an ischemic myocardium could reduce heart failure hospitalization. I like the plasma volume reduction hypothesis. I think it's much more likely to be responsible for such a rapid effect in heart failure hospitalizations and CV death, but I think we just don't know. But the changes in hematocrit and increase in hematocrit appear to be very, very important. This now is a study that we conducted here at Yale University. This is from my colleague Jeff Testani's group, who's a cardiologist interested in heart failure and the kidney. And when an SGLT2 inhibitor, in this case empagliflozin, was added to patients with heart failure, you can see that there is a small natriuresis, an increase in the fractional excretion of sodium, but when the SGLT2 inhibitor was applied alone. But when combined with a loop diuretic, the effect appeared to be almost synergistic, which is a very provocative statement, because I think synergism across diuretics is a very alluring side benefit of using a different medication in patients with heart failure hospitalizations, meaning that these drugs together could reduce plasma volume to an even greater extent. In fact, we demonstrated that the change in plasma volume and the change in total body water was statistically significant in the empagliflozin group. And interestingly, if you do the math, this type of reduction in blood volume translates exactly to a 3% increase in hematocrit, which is what we see in other larger studies. Now, despite the plasma volume reduction, you think that would lead to neurohumoral activation. This is not what Jeff demonstrated, that when you look at norepinephrine, plasma renin, aldosterone, all the compensatory mechanisms that the body has to fight plasma volume reduction, you just don't see the changes that you typically see with conventional diuretic therapies. So there is clearly a heart failure benefit with the SGLT2 inhibitors. Now, I will point out that there is a new study called VERTIS-CV that I didn't have an opportunity to put on my major chart of SGLT2 inhibitors, but here the MACE effect was neutral, but there was a 30% risk reduction in heart failure hospitalization, statistically significant. So everything is consistent with SGLT2 inhibitors. Well, this led to lots of interest in the cardiology community as to whether a new and supposedly important drug class. Important drug class for patients with type 2 diabetes as regarding heart failure hospitalization could have a benefit in non-diabetic patients. So here's a drug that appears to reduce heart failure events. Maybe you don't need glucose reduction to have a benefit from this medication as related to heart failure. So this led to the DAPA-HF trial that randomized more than 4,000 patients to dapagliflozin, which is another SGLT2 inhibitor, and patients were tracked for a median of 18 months, with the primary outcome being cardiovascular mortality, heart failure hospitalization, and urgent outpatient heart failure visits requiring IV diuretic therapy. These are the baseline characteristics of our patients. You can see that the mean ejection fraction was 31%, and the mean NT-proBNP was more than 1,400. And importantly, less than half of our patients had a previous diagnosis of type 2 diabetes. This is a primary outcome, 26% relative risk reduction in CV death and worsening heart failure. If you divide the two components of the composite, worsening heart failure on the left, 30% risk reduction, cardiovascular mortality on the right, and 18% relative risk reduction. And you can see this early divergence of the heart failure event curves, perhaps less early than with Empareg, but still around 3 months, you start to see this divergence of the cardiovascular death Kaplan-Meier curves. What about the important question of type 2 diabetes, and did it modulate the efficacy of dapagliflozin and DAPA-HF? Absolutely not. So, point estimate, 0.75, 0.73, no heterogeneity whatsoever. So whether you had or did not have type 2 diabetes in this heart failure study, the medication worked similarly. I forgot to mention that DAPA-HF was a HFrEF study. So this is heart failure with reduced ejection fraction. There are HFpEF studies that are currently underway. A second study that was just announced, the EMPEROR-reduced trial, very similar trial design to DAPA-HF. This is now using the SGLT2 inhibitor empagliflozin, and you can see that the hazard ratio of 0.75, 25% risk reduction in CV death and heart failure hospitalization, nearly identical in this additional HFrEF study to what we found in DAPA-HF. And again, they did take a look at diabetes versus no diabetes, and there is very, very similar effects. Now, as we pointed out previously, in addition to heart failure hospitalizations, the CKD effect of these medications is quite prominent. The Virtus CV that has not been yet included in this slide chart was also moving in the right direction, although for some reason the effect size here, 19%, with a p-value of 0.08, was not statistically significant, although the Virtus investigators just recently presented data at the EASD, the European Diabetes Meeting, showing that when they changed the definition of the renal composite to a more acceptable definition for the decline in renal function, which is a 40% reduction in GFR, I think they chose a doubling of creatinine, which is translating to a 57% risk reduction. When they modified the definition, you had a statistically significant effect, which is on par with what we see with these other trials, 39, 40, 24, and 30%. Now, DAPA-CKD was recently announced its results, and there was a 39% reduction in this primary outcome, which was a 50% decline in GFR, end-stage kidney disease, or renal or cardiovascular death. DAPA-CKD is analogous to DAPA-HF because it recruited patients with CKD, defined by decreases in GFR in the presence of albuminuria, whether or not they had type 2 diabetes. And you can see here in this subgroup analysis that, well, first let me show you that the components of the primary outcome, which again is this composite of 50% decline in GFR, the development of the end-stage kidney disease. Some of these point estimates are not lining up with the actual lines, the actual rows here, but suffice to say that each of these components were positive. CV death not statistically significantly reduced, but certainly going in the right direction. And here are the subgroup analyses. And this is the one I wanted to show you, the diabetes versus no diabetes. And you can see that the hazard ratio being 0.64 for diabetic patients, even stronger, at least by the eye, although not statistically significantly different, at 0.50 in the non-diabetic patients. Well, let's conclude by discussing how these exciting data now have impacted treatment guidelines. This is the ADA-EASD position statement that was published in 2012 and then updated in 2015. And in this algorithm, the group felt that metformin would be first-line therapy because of its safety, low cost, and efficacy. And then after metformin, one of 6 additional medications would be used, picking them based on side effects, potential additional benefits, but no firm data in terms of comparative efficacy research linking one versus the other drug to definitive benefits on the cardiovascular system. And that's changed since 2015 very, very clearly. So this was basically a guideline to say that metformin and then choose whatever you want. Nowadays, this is now the latest ADA-EASD guidelines. The first question you ask is whether patients have established ASCVD, CKD, or heart failure, because those are the data that are now emerging from these large cardiovascular outcome trials. And if the answer is yes, then if cardiovascular disease predominates, atherosclerotic cardiovascular disease, either a GLP-1 or an SGLT2. However, if heart failure or CKD predominates, then an SGLT2 inhibitor would be the optimal second-line therapy after metformin. I would point out that you do have to have sufficient renal function to benefit from an SGLT2 inhibitor because of its effects on glucosuria, but that marker for when an SGLT2 inhibitor is no longer effective is getting lower and lower because some of the CKD trials were getting down to 20 to 25 on GFR. Most drugs are labeled for use down to 30 to 45, depending on the country. This is now the ESC, the European Society of Cardiology guidelines for diabetes management. Cardiologists are very interested in diabetes. And here they push the envelope a little bit more, stating that in drug-naive patients with cardiovascular disease, that an SGLT2 or a GLP-1 could be used even instead of metformin, so not even considering metformin as foundation therapy. And they also open up this treatment algorithm to patients at lower cardiovascular risk, in other words, patients who don't have just established CVD, but other risk factors as well. So the SGLT2 inhibitors in DECLARE and CANVAS have shown now prevention of the progression of CKD, prevention of heart failure, and also treatment now, starting with EMPA-REG, CANVAS DECLARE, and now directed trials at patients with substantial cardiac or renal disease, DAPA-HF, DAPA-CKD. We looked at EMPEROR-reduced and CREDENCE as well. So across the spectrum of cardiorenal disease, the SGLT2 inhibitors appear to be very important treatment options for patients with type 2 diabetes. There are still some studies underway. So EMPEROR-preserved, as the name would suggest, is a HFpEF study using empagliflozin. DAPA's HFpEF study is known as DELIVER. We'll have results in both of these in 2021. And then EMPA-KIDNEY is a renal study using empagliflozin analogous to DAPA-CKD. Well, let me conclude. My time is up. Heart failure and CKD are frequent complications of diabetes, and they each confer poor prognosis. SGLT2 inhibitors have been consistently demonstrated to lower heart failure hospitalization rates in patients with cardiovascular disease or multiple risk factors, including those with or without a prior history of heart failure. SGLT2 inhibitors have also been consistently demonstrated to reduce the progression of chronic kidney disease, including hard renal outcomes like GFR decline and end-stage kidney disease. And in the dedicated heart failure with reduced ejection fraction and chronic kidney disease studies, SGLT2 inhibitors have been shown to improve clinical outcomes in both patients with as well as without diabetes. And clearly, diabetes guidelines now endorse their use in patients with type 2 diabetes with concurrent heart failure and CKD. And with that, I will conclude, and I thank you very, very much for your attention.
Yeah, thank you, Professor. And tonight we have the audience raise the issue and a question from the internet, and I will raise the question for Professor. And okay, Professor, is it okay?
Yes.
Yeah, okay. Yeah, because just this afternoon we received the AJM paper about DAPA-CKD. We have mentioned about the cardiovascular death issue in your slide about the EMPA-RAGE and the DAPA-HF show the cardiovascular death is significantly statistically significant, but not for the EMPEROR study and DAPA-CKD. And also we see the footnote of the DAPA-CKD should denote about the statistically number not applicable because the p-value for the efficacy outcome is reported for only outcome study, not for the cardiovascular death. So is there any further explanation for why the hospitalized heart failure is the main driving force for the composing the point, not for the cardiovascular death for EMPEROR study and the DAPA-CKD?
You know, when you do clinical trials, you choose a primary outcome as a composite because you need to keep the numbers in these trials reasonable. You have to be able to recruit, you have to be able to pay for the study. So you power the study based on the composite. You don't power it based on the individual components. So in many trials, there is a numerical reduction in each of the components of MACE, but they don't all achieve statistical significance. If you double the size of the trial, you probably would. So I can't tell you why epagliflozin was not associated with a cardiovascular mortality benefit in EMPEROR reduced. It certainly was going in the right direction, and that SGLT2 inhibitor has demonstrated cardiovascular mortality benefit in a larger study, the EMPEROR outcome trial. So whether this was because it was a smaller study, I will point out that the LV dysfunction in EMPEROR reduced was a little bit greater than in DAPA-CKD. I think the mean ejection fraction was in the mid-20s as opposed to 31. Maybe if you're too sick, if your LV dysfunction is too severe, maybe there's not enough time to garner a cardiovascular benefit. But you know, I think we can sometimes get too concerned about individual components. You don't like to see the component going in the opposite direction, right? You don't like to see an increase in the event rates. But I don't think that the lack of finding in a CV mortality, whether it's in DAPA-CKD or in EMPEROR reduced, is all that meaningful because the composite was reduced.
Yeah, okay, I see it. And the very next question about as heart failure seems to be a life-threatening complication in type 2 diabetes, how could we early recognize a patient with heart failure risk in daily practice?
Good question. I think that I think anybody with diabetes is at increased of heart failure. Certainly the combination of type 2 diabetes with CAD increases the risk of heart failure. Very clearly, age is a major risk factor, and kidney dysfunction. So lower the GFR, the greater the risk of heart failure. So if you plug in those characteristics in a model, diabetes, coronary disease,
Mm-hmm.
CKD, and age, particularly age over 70, those are very powerful risk factors for heart failure. There are risk models that the TIMI group has published one, the Health ABC study has published one, and they all incorporate those factors.
Yeah, about years ago, there's two studies for Pontiac diabetes and non-diabetes show the proBNP may be a biomarker for prediction for type 2 diabetes heart failure. Do you agree with it?
Yeah, no, without question. I mean, the biomarkers, NT-proBNP, and also high sensitivity troponin, which is a biomarker for cardiovascular events, MACE events, are something that is underutilized in the diabetes community. I know cardiologists have long used natriuretic peptides and other markers of myocardial injury, but maybe newer models will incorporate those. I mean, there's some challenges in interpretations. NT goes up in atrial fibrillation, NT goes up in CKD, it goes down in obesity. So there are some interpretive challenges, I think, with these natriuretic peptides. But yes, absolutely.
So maybe in the future. Thank you.
Maybe, yeah.
And the next question is about there is more evidence for type 2 diabetes and SGLT2 inhibitor, but is there any evidence for SGLT2 inhibitor for pre-diabetic patient or ongoing
Well, yeah,
study?
I mean, we have 55% of DAPA-HF patients did not have diabetes. 2/3 of those had prediabetes. I mean, as a cardiologist today, know when you look at a heart failure population, it's about half already have diabetes, and of the other half, the majority have some dysglycemia. Why that is not quite clear. This is probably all a spectrum of disease, cardiometabolic disease, as we've cardiorenal metabolic disease, as we've talked about in the past hour. We actually looked at the pre-diabetic subgroup, and they have a similar effect. Most of that was already demonstrated in the subgroup of non-diabetic patients because 2/3 of those patients have pre-diabetes. One interesting sub-analysis that we presented at the American Diabetes Association meeting in June and is currently under review is the diabetes prevention possibility of dapagliflozin. And this was obviously in pre-diabetic patients. We demonstrated that the effect of dapagliflozin on new onset diabetes was to reduce it by about 30%. So now that's not the reason to use the medication, because the benefit was, the more important benefit was on death, right? And heart failure hospitalization. But hey, if I was a patient and you told me, would you take this additional benefit of preventing the diagnosis of diabetes and all the implications of that and all the additional medications that may be used, I think it's a nice side benefit.
Yeah, follow the question. In the slide 19, there is Dr. Zeniker has showed the data about multiple risk factor and established the cardiovascular disease for the role of SGLT2. Should we use the SGLT2 to inhibit type 2 diabetes as early as possible?
You know, I'm starting to think so. I'm coming around to this notion that when you look at all these subgroups, CVD, no CVD, heart failure, no heart failure, even the protection against decline in renal function does not necessarily need renal dysfunction. So if you have patients with maybe not normal GFRs, but pretty good GFRs of 60 to 90, even those patients seem to have improvement in their decline in renal function. So the guidelines nowadays are specifically targeting established disease, but now you can see that they're growing a bit in terms of suggesting that even risk factors patients maybe one day will say that, you know, this is foundation therapy. Maybe everybody should be on metformin plus an SGLT2. There's actually a primary care consortium from Europe called Primary Care Diabetes Europe, PCDE. And I believe that they either have already presented or are working on the guidelines from their perspective that says early combination therapy is the way to go, either with a GLP-1 or metformin, or metformin with an SGLT2 inhibitor. You know, you teach about rational use of medications. I've been doing this for, I won't say how long I've been doing this, but you try to teach residents, fellows, primary care physicians about the rational use of these medications.
Yeah.
And sometimes you question whether we as endocrinologists obsess about the mechanisms and the additive benefits, but you know, sometimes a simple message is better, which is, you know, like diabetes, metformin. I think that message has gotten through. It's taken us, you know, 15, 20 years, but the message, maybe the message at one point, I'm not suggesting this because I think we need more data, and there's obviously major cost implications. In the US, these drugs are $500 per month. I mean, it's a little crazy. I'm not sure what in your country and other countries listening tonight, what the costs are, but they're very expensive. They will be at some point generically available, which will make that. And maybe at that point, we will say, if you have diabetes, you go on metformin because it's just a favorite of ours. There may be a cardiovascular benefit. And then you go on an SGLT2 inhibitor because of the renal benefits. So maybe we'll get to that point.
Yeah, I think that if there's no financial problem, I think it is a medical question. But for the financial problem, it is a philosophy problem, not only for the medical. Yeah, follow the question is about the years ago in British, we know that the 10 milligram simvastatin was used to be the counter medication to prevent cardiovascular disease instead of the prescribed medication. So does the benefit of heart failure and renal protection for SGLT2 inhibitor could be achieved when lower dose of medication, for example, 5 milligram dapagliflozin?
I don't think we know. I mean, I think all the studies declare use 10 for the most part. DAPA-CKD use 10. We had some discussions about whether we should go with a lower dose because many of us involved in DAPA-HF, I should say, many of us involved in that trial were worried that we were going to induce acute kidney injury, volume depletion, patients with syncope, because these patients have very labile intravascular volumes, right? They tend to be overloaded, but many of them are actually dry because they're on high potency loop diuretics, MRAs, some thiazide. So when you add another diuretic to that mix, we were concerned that we were going to suffer lots of adverse events. It didn't come to that, but we at one point thought about using the lower dose, 5 milligrams, but we decided to go with the full dose of 10 milligrams. So we don't know. We don't know.
Yeah, I see. But we could share experience in Taiwan. Sometimes if you want to save the money for the cash, you can use half dose of the dapagliflozin, for example, for the split dose. So sometimes it's a financial problem, not for the really medical issues.
Yeah.
And the very next question is why both Vertis CV and Emperor reduced study show the trend of late catch-up in Kaplan-Meier curve?
I'm not sure what late catch-up means. Does that mean that there was a initial benefit and then a narrowing of the event curves? I didn't.
A long time they should. Yeah, I think so.
I didn't see that, or I didn't catch my eye. I'm looking now at the Emperor curves here, and I don't see a catch-up. So I'm not sure if that person can re-ask the question. I'm just not sure what that means, because at least I'm sorry, I'm looking at DAPA-CKD.
Yeah.
Even in DAPA-CKD, they do continue to diverge, suggesting that the longer you take, the less there is. I'm looking now at the Emperor reduced curve, and I don't see any catch-up. I mean, there's not a huge progression of the divergence, but they seem to be at the very least parallel. One caveat, we talked about the caveat of overanalyzing the composites of these components. We as clinicians, investigators, like to overanalyze things, but sometimes we overanalyze what happens on the right side of these Kaplan-Meier curves. But when you look down and you see the numbers of patients that are still involved in the trial, whose data is contributing to the 2.5-year data, the 3-year data, you realize that there are very few patients left in the trials, right? There may be 100 or 200 patients, and therefore there's a lot of noise that occurs toward the right-hand side of the event curves, and that's why they get very labile. There's lots of movement, whereas there's much more smoothness, if you will, on the left hand, because there are thousands of patients involved. So you have to be a little bit careful at overanalyzing some of these event curves.
Yeah, but for the both study as a similar point, because the Vertex CV has shared about 27% of patients with heart failure, and the Emperor study for the reduced ejection fraction. It may be, I think that the medical issue for the late catch up may be just a minute, I guess.
Yeah.
Okay. Yeah. The very next question is, does DAPA beat CANA in CKD patient for renal protection after DAPA CKD trial?
No, I mean, this is the third observation of overanalyzing trials, is that we are always very tempted to compare trials, one versus the other, but you can't, right? Because they're different methods, they're different patient populations. So if you can say that the DAPA CKD progression of CKD was a little bit stronger than with canagliflozin and credence, I think that's over analyzing. I don't think you can say they're roughly the same.
Yeah, but CANA in credence focused on type 2 diabetes only, but the DAPA CKD include diabetes or non-diabetes.
Without question, but I don't think any of us would say that if you applied canagliflozin to a non-diabetic population, you wouldn't see the benefit.
Yep.
The major issue, obviously, with CANA is that it was stained to some degree by this observation of a doubling of amputation rates, but only in one study. Remember, that was a Canvas trial.
Yeah.
Wasn't seen with other drugs, wasn't seen with other canagliflozin trials, but is still something that is disturbing about the potential for this class to do that. So I think at least in the U.S., the preferred agents have been DAPA and EMPA for that reason. But I think there probably is class effect, right? There's effect, at least on heart failure hospitalization and CKD. I can't tell you why erdagliflozin didn't seem to have that same effect, at least on the kidney. But as I mentioned, when you redefine the kidney outcome, it's really not dissimilar.
Okay. The very next question is, what do you think, how low for the eGFR can use SGLT2 inhibitor? Because the canagliflozin can use around or less than eGFR 30 until the patient receives the dialysis. So what is the eGFR lower level for SGLT2 inhibitors?
I'm very comfortable using them down to 30. Okay. The latest trials, and now remember, credence did not go below 30, although some may have dipped under 30 during the trial, but at least at baseline. DAPA CKD, I believe, was 25, and I think that EMPA kidney is going to go down to 20, and even EMPA reduced, I think, went down to 20 as well. So now endocrinologists get a little nervous when you start getting under 30. So because the problem, as you know, is that there is a almost uniform reduction in GFR in patients who take these medications. The amount of reduction can be variable, but almost everybody has at least slight reduction in their GFR. So if you start at 20, you could easily get into the teens, and I think at that point you become a little bit nervous. But the nephrologists that I speak to are a little bit braver because they're used to using RAS blockade, which does a very similar thing, and they still feel that that is something that suggests protection as opposed to any worsening of renal function.
Yeah, although they cannot decrease the serum glucose level further, but they can decrease the risk.
Yeah, that's an important point. If you're thinking about using these drugs under 45, there is very little glucose lowering effect because you're not filtering that much glucose. I mean, you obviously are to some degree, but you don't just get enough throughput of glucose to have any substantive reductions. But there's still a blood pressure effect, which is it's modest, but it's measurable. and there's definitely an outcomes benefit as well.
Okay. The following question is very interesting for the adverse event or safety issue. That would a genital tract infection still common side effect when using SGLT2 to treat heart failure patient without diabetes?
Yeah. You do induce glucosuria because the threshold for glucose excretion is lowered to below 70. So even if you're walking around with blood sugars of 90 or 100, there will be glucose in your urine without question. And, we think that that's the cause of the yeast infections. And we probably should, I focused on benefits of these medications, but the main issues regarding safety are, number one, this genitourinary infection. So that's the mycotic infections, yeast vaginitis, yeast balanitis in men. It tends to be more common in women than men, and in uncircumcised men, it can be more common. It's usually treated with topicals, and it's usually not much of an issue. But the other concern is urinary tract infections. That was a concern initially, but doesn't seem to be a major issue in the large trials. But I would not necessarily use the medications if there's an indwelling Foley. And then the other concerns are the polyuria that patients will have. So in older men with BPH, you have to be a little bit cautious. But the answer to the question, and I know we're running out of time, the answer to the question is yes, you do see genital infections even in non-diabetic patients, but we did not track that carefully because this was a phase 4 trial, and we only captured genital infections as as serious adverse events, not as any adverse event.
Okay, but just wonder about, is there really gender difference for the genital tract infection? Gender difference for male or female?
I think the relative risk is about the same. It goes up by about threefold. But because the underlying risk in women is much higher than men, I mean, it's about 5%, so it goes up to about 15%, 12 to 15%. In men, it's 1%, so it goes up to 3 or 4%. So it can occur in both genders for sure.
Yeah. Okay. After the several study launched from 2019 to 2020, will you suggest to use SGLT inhibitor in the second line diabetic treatment instead of the DPP-4 inhibitor?
Yeah, I mean, if there's anything like cardiovascular disease, heart failure, CKD, risk factors for those, the more you start including patients who would benefit, the less patients are left. So I guess a totally healthy patient who needs a little bit more glucose lowering effect, DPP-4 inhibitor would work well. Probably less side effects. I mean, let's be frank, when you're having discussions with patients, it takes a few more minutes to prescribe an SGLT2 inhibitor. They have to tell them about the urinary frequency, the potential for mycotic infections. With the DPP-4s, it's like, here's a medication, no side effects, it'll lower your glucose. So there is ease. I mean, that's one reason that the DPP-4 inhibitors, which are not that potent medications, they don't have any additional benefits. It's one reason that they're enormously popular. I know in Asia they're enormously popular. They may work better in the Asian gene pool than in the Caucasian gene pool, but I do think there's probably still a role, and many patients will require triple therapy. So the nice triple combination of metformin, DPP-4, and an SGLT2 is something that you can get substantive reductions in glucose with.
Yeah, generally DPP-4 inhibitor is a very easy and a safe issue for a medication for endocrinologists.
That's right.
Yeah. Okay. I will ask the last question from the audience is to be early aware of renal dysfunction, and would you recommend frequent use test eGFR, UACR in diabetic patient, even their eGFR seem good? And how often would you recommend?
Well, the labels, at least in my country, do not suggest the need for tracking renal function more than once a year, just routine diabetes care. What I do actually, especially in patients who have some underlying CKD, is I recheck after 1 month. It's not necessary, I just want to see it, because I think if there is a more dramatic drop in GFR, you'd have to discuss whether ongoing treatment is necessary. But again, my kidney colleagues make fun of me because they say you don't need to do that because even if it goes down, you're still benefiting. I still like to know. So I do urinary albumin before, GFR before, and 1 month later. I like to know. It's a relatively inexpensive test, and I think it's comforting when you see just minimal reductions, which is what you typically see.
Yeah, I see. Thank you, Professor
Okay.
Insuki. Very happy night for me because I can introduce the hero and the master of the endocrinologist in Taiwan. Yeah, and the very last section I will quote the statement from your speech before. The endocrinology is fascinating, and we can usually be able to help patients to improve their quality of life through multidisciplinary care and academic approach to endocrine conditions. You said it before. So this night we can use the new medication for SGLT2 inhibitor and via new study. And in comparison with the prior study of DPP-4 inhibitor, we are very happy to listen to lecture from Dr. Insuki to teach us more new education for us. And thanks the audience and thank the ladies and gentlemen. And it's a happy night for us. And thanks the sponsor for AstraZeneca. It's a very happy night for me, and I think it's a very happy night for the audience. And I hope you have a very good morning for the Professor Insuki.
Thank you very much. A pleasure to be here with you.